before I forget. All right, so we're going to get started. This is actually a very short chapter, at least as far as my part goes. This is a hard chapter to teach, so bear with me, because there's not a lot. It's basically like trying to teach you a new language. We're going to be going over medical terminology tonight and talking about how the words break apart. We'll do some practice runs. I'll give you guys, we'll talk about like body part locations. Like if I say you have an injury on this arm in this spot, how would you, or if I, yeah, where would it be? Or if I said, you have an injury above the elbow, how would you describe that kind of thing? But we're going to work on this tonight. We're going to work on this pretty much through the entire class. So if you don't get this, it's kind of like anatomy. If you don't get this right out the gate, that is perfectly fine. You're going to get practice every single day that you read the book, every single day that we go through class. I'm going to have you guys talking in medical terminology. So if I hear or see somebody say something in plain English where they're talking about above the heart, I'm going to okay, say that and use your medical terminology. And the reason that I do that is because your registry test is going to use almost strictly medical terminology. And so you have to be real quick on what pulmonary means or what, tachycardia or hypoglycemia. You should be able to pick those up real quick as you're going through those questions. If you have to stop and sit there and stare at a word for a while to try to remember what it is, it's not going to work out in your favor. Even if you get it, it's going to slow you down to the point where you may run out of time on the test. So this is important. It's important beyond this chapter. Same thing with your anatomy, but when we get to different body systems as we go through the course, we're going to review the anatomy for that system. So just like when we hit chapter 6, which I believe is anatomy, don't beat yourself up if you don't get it on the first night. It's perfectly fine. All right. So as an EMT, you got to have a strong working knowledge of medical terminology. Again, you can say in one word, if you use the right word, what would take you an entire sentence to say if you tried to use plain English. Not only that, but a lot of times your patients are going to tell you, because you're the experienced EMT and the one that they're looking at for help, right? So when you ask them their medical history and they tell you they have hyperglycemia or type 1 diabetes, well, it's not really medical terminology, but we'll say cardiomegaly. What does that mean? You don't want to get that glossed over stare in your eyes, and then they'll be like, "Are you still with me?" That kind of thing. So not only are you going to have to use these words, but you have to understand them when they're said to you as well. Because sometimes somebody will say something to you that is actually really important for you to know. And if you don't know the word, it will fly right over your head. And then you run the risk of giving the wrong medication or doing the wrong treatment, going down the wrong rabbit hole, that kind of thing. Or you'll just miss something. And then that small something winds up being the reason they go into cardiac arrest. But for effective communication and documentation, you must understand key terms, acronyms, like, for example, COPD, symbols, and abbreviations. You can determine the meaning of an unknown word if you break it apart. This is like any science class you guys have taken. You get these massive words in your biology book or whatever, and you're like, I don't know what the hell this means. So break it apart. If you understand how, like, the root and the prefix, the suffix, and all that, how they fit together and what those parts of the word mean, even if you get this massively long word, but you have no idea what it means, if you can sit there and find those different sections, you can kind of piece it together and figure it out. So understand how the terms are formed, and learning the definitions of parts of a medical term are important. Understanding medical jargon will help you communicate effectively with other members of EMS, healthcare, and public safety teams. Again, especially when you're talking to, like, say, your med control. I hate to say that they'll do this, but they absolutely will do this. They will judge your knowledge and your competency by your ability to do or to speak to them on their level. So, you don't want to call the doctor and say, yeah, his heart's beating slow. That's not a good way to put it, right? So we're going to say bradycardia. And you'll learn these things, like what's bradycardia mean? What's apneic. What does that mean? If I tell you that you have a patient that's pulseless and apneic, well, pulseless we understand, but if you don't know what the word apneic means, um, that's not a good thing, because that technically means they're not breathing. So if you don't know that word and we're just talking about a patient, you might not do anything to take care of their breathing because you didn't realize that that word meant they weren't breathing. All right, so medical terms are made up of distinct parts that perform specific functions. And if you change or delete any of those parts, you can actually significantly change the meaning of the word. So we have a couple different parts. You have the word root, which is the foundation of the word. It's usually the middle. You have the prefix, which comes at the beginning, and the suffix, which comes at the end. So if I think of it like, all right, we said apneic a second ago. Starts with the letter A, and then it's P-N-E-I-C, if you've ever seen that word. The A at the beginning means without. And the P-N-E-I-C, the P is technically silent if you say it by itself, but if you put the A there, it's apneic. That means breathing. So apneic or pnea means without breathing. And then the word I threw out a little while ago, cardiomegaly. Cardio being that is the word root, right? So cardio means what? What do you think? If I were to say anything that had cardio in it, what am I referring to? The heart. Good. All right. So we're talking about the heart, and then megaly. So think about that suffix for a second. What's the word mega mean to you? Big. So if I said cardiomegaly, we put that together, you have a big heart or an enlarged heart. Um, that's another example of how those words kind of fit together. And good job, you guys picked up on the parts. So this will be a pretty easy class. I think you guys will get it pretty quick. But like I said, it comes with practice for those of you that haven't been exposed to this before. So your prefix comes before, your suffix comes after, and then you have combining vowels. So we talk about gastroenterology. That's a field of medical practice talking about the GI tract and everything. If you have gastric and then enterology. The reason we say gastro, that O is actually a connecting vowel. They replaced the IC from gastric and put gastro so that it connects to the rest of the word. So you're going to see that too. Don't get so bent around the wheel about those combining vowels. They're there just to make it a single word. All right, so how you combine the terms basically determines its meaning. So we do, one of the big things about that vowel, and we backtrack on that, is right there in this slide. So accurate spelling is essential. Again, it's not, you want to be able to say it and know it when you know what you're saying and know what you're hearing, but we document this stuff, and this stuff goes to courts, especially when people don't like how their treatment went or the treatment didn't work out very well for them. It's really important because, again, you will be judged by this. So use your autocorrect. Don't trust it. I'll say that because sometimes a lot of medical words just flat out don't show up. Use it if you can, but if it looks right to you and the whole word is just lit up in red saying that it's misspelled, put it into Google. I would recommend doing that because Google a lot of times will tell you how it's supposed to be spelled, whereas your typical Microsoft Word autocorrect may completely miss the shit. So spelling is important. And here's an example of that. So like phasia. Phasia with an S means speaking. Phasia with a G means eating. Both have to do with the mouth and that area of the body. So that's why they're so close together. But one is about communication. The other one is about eating your food. So if you said somebody had dysphagia, depending on how you spelled that, that could be a very big difference in what you were saying. Dys means difficult or painful. So is it trouble speaking? Does it hurt for them to talk, which would be more of a laryngeal area around their vocal cords? Or is it dysphagia, like they have difficulty eating or swallowing, which could be further up? Now you're talking about something in their oropharynx that could be swollen, like their tonsils. That's why spelling is really important. All right, so how the parts of a term are combined determines its meaning. We already talked about that. It's important that you know the anatomy that you're talking about. So I know that when I was trying to learn this stuff myself, I kept getting cephalic, the word cephalic mistaken. And then I would be trying to refer to kidneys, but I would use the term for the head, and got some really weird looks from my instructors because had no idea. You ever talk to somebody in a different language trying to say it right and then you screw it up, or you have somebody do that to you in Spanish or French or something like that, and they're trying to speak in English, but they completely jack the saying up, and you're just looking at them like, what did you just call me? Um, it can be it can be pretty similar with this. So the main part or stem of a word is called the word root. That's usually the main word that refers to what we're talking about, like cardiomegaly. We talked about that. That conveys the essential meaning of the word, and it frequently indicates a body part. Most terms have at least one word root. Some can have more than one, but it's pretty rare. Adding a prefix or a suffix to the word root creates a term, and changing it will change the meaning of the term. So that's, again, we got to make sure that we get the right thing. Every day in my Spanish class, the funny thing is I was trying to learn Spanish, and I got on my standards, I got pretty good at it until I tried to talk Spanish to a friend of mine who's a Spanish instructor at a college, and almost got slapped. So maybe I wasn't as good as I thought I was. But so anyway, be careful with how you change words. It can just be one letter that makes a difference, like hyper versus hypo. Some of our students are well aware of like the difference between hyperglycemia and hypoglycemia. One means low, one means high. All right. Let's look at the word. Let me have to get my slide up to where we need to be. There we go. Okay. So let's look at cardiopulmonary and how that word breaks down. We talk about CPR all the time, right? What does that stand for? Cardiopulmonary resuscitation. So you're resuscitating two things when you do CPR. You have the cardio and the pulmonary. So the chest compressions in CPR is trying to resuscitate the heart, and your two breaths after every set of 30 compressions is trying to resuscitate the lungs. You're basically doing the work of both for the patient when they're both out like that. But for those of you that have gone through the AHA's BLS training, what do you do if somebody has a pulse but they're not breathing? What's that called? Anybody have a clue?
You're asking what we do when they don't have a pulse and breathing, as in rescue breathing, or?
That was what I was looking for, was the term. So yes, if I were to say that you're doing CPR, that tells me, or you told me you're doing CPR. If you're actually doing CPR, that tells me that you're doing the full shebang. You're doing chest compressions and breathing. But if you were to pass down a patient to me that you said had a pulse but no breathing, it wouldn't be CPR you were doing. It would be rescue breathing. You'd be taking care of their breathing, but their pulse is fine. That's kind of what I was getting at. So, CPR stands for cardiopulmonary resuscitation. If you're going to say that you're doing CPR and you're using the right word, that tells me that you are absolutely doing both. You're taking care of both systems. That's the importance of that, because if you tell a doctor you're doing CPR and really all you're doing is rescue breathing, they're going to be getting ready to set up all kinds of advanced meds from lidocaine to epi, dopamine, all this stuff, amiodarone, and they don't need any of that because all of that's cardiac drugs, when really all they needed was something for their airway to try to kick their airway back in. All right, so let's move on to prefixes. A prefix is the part of a term that appears at the beginning of the word, and it usually describes your location or the intensity. Prefixes are found in general language. We use this all the time. So like autopilot, submarine, tricycle. Not everything has to be medical, but most all of our medical terms have a prefix, especially when we're talking about something that's wrong, right? Because that prefix is usually referring to the problem. Hypoperfusion, the prefix is hypo, and it's saying that your perfusion which by itself is something that's great. That's your cell's ability to transfer oxygen and gas, but hypo being the prefix tells you that something's wrong. It says that that is low. For some reason, you're not getting that gas exchange like you should be. Or hyper, it's almost never happen. I don't even think there is a such thing as a hyper. I only ever hear hypo. All right, a prefix gives the word root a specific meaning for, like I said, we talked about breathing, for example, the word root, nia. One can add the prefix a, which means without, or brady for slow. Tachy means fast. Any of those words can tell you basically the rate of breathing. So if they're tachypnea, they're breathing too fast, and we'll get into what the ranges that we're looking for are in another chapter. But if they're bradypnea, that tells you that they're breathing too slow, or apneic means that they're just not breathing at all. By learning the commonly used medical prefixes, you can figure out the meaning from there, especially for words that aren't necessarily that common to you. There's all kinds of words, and they get made all the time. A buddy of mine, when I was in high school, kept going to the doctor because they couldn't figure out what was going on. He had a medical condition where he would just lose blood. It would seep out of his veins. He would start to get lividity sitting there talking to you. It was the weirdest thing, but it was a life-threatening issue, obviously. He's in and out of the hospital all the time, getting blood transfusions and all this stuff. They could never figure out what was wrong because they kept looking at existing known issues. And they finally wound up, they gave up trying to pin it down on a name. They just gave him one. um, I don't know if he was really patient zero for that, or if it was just so obscure they couldn't find it. But they gave him his own term, the condition that he had. And when he came back and told me, he had to write it down. It was so long he couldn't say it. But it basically, looking at it now, if you break the word apart, it basically just said it boiled down to blood won't stay in the veins. But they made this huge medical term to say that because they really had no clue. There was nothing else that they could really put there. So let's talk about suffixes, because now we're at the end of the word, right? Suffixes are placed at the end, and they usually indicate a procedure, condition, disease, or a part of speech. So an example one, and you're going to see this all through this class, learn this one. It's itis. All right, commonly used. This is probably the biggest one you're going to see. Anything like tonsillitis, appendicitis, laryngitis, bronchitis, any of these words that you've ever heard, they're basically just saying that it's an inflammation of whatever body part you're referring to. So in this slide, arthritis. Arthro is your joints, and then itis is inflammation. So like myself, I don't know what I was doing to cause it, but I've been dealing with it for a few months now. I've got basically arthritis, whether it's chronic or not, I don't know, but it's in my both hands, my index and ring fingers where they connect to my hand itself. I've got some swelling going across both of those knuckles, and I guess I'm just getting old. I don't know, but there's no other word for it. And I'm trying to talk to my doctor about it. He's like, "You got arthritis?" I'm like, "Yeah, but not like, I don't think I've got arthritis to the end of time kind of thing. It just kind of popped up, but who knows? I mean, it's still the right word, even if it's not how we commonly think about it being arthritis, being like rheumatoid or something that elderly people get. So when you combine words, now we're looking at those vowels. So connect these words. This is what you do when you want to connect two separate words that don't normally fit together, like, hypoperfusion goes together. But if you're trying to connect two different root words, you're going to use a combining vowel. So in most cases, it's an O. Sometimes it's an I or an E. But usually it's like gastroenterologist, as an example. Interesting that the word I chose is actually the word that's on the slide. So here's your example. The word gastric means to do with the stomach. Entero has to do with the intestines. So what they do is they take the IC off of gastric, they put an O there, and then that allows it to connect to enter so that they can make gastroenterology. And anything ology is like geology, all that. Those are the study of. So gastroenterology by itself is the study of the stomach and then the intestines. Here's some other words that you may see. You're going to see actually a lot of these a lot in the chapters. So some common combining forms. You have cardio for the heart, like cardiomegaly, gastro for the stomach, hepa, that is your liver. So when we talk about hepatitis, you already know what itis means. So what does hepatitis mean?
Infection of the liver.
Not an infection.
Inflammation.
Sorry. There you go. Sorry. It is an infection, but the word itself breaks down to inflammation. So inflammation of the liver, arthritis, same thing. Osteoarthritis is a thing. So that's an example of where you would actually use the connecting vowel osteo to connect to arthro. And then pulmonary, anything pulmo is your lungs. So pulmonologist, pulmonary contusions, things like that. You'll learn what all those are. But anytime you hear pulmo, that's lungs, and then the O is how you would connect it to other words. Some word building rules. If you guys ever have to, I'm not going to make you create your own medical terms in this class, but if you're ever stuck with something that just a word doesn't come to mind and you have to piece something together, here's kind of the rules that you would follow. When building or taking apart a medical term, it is helpful to understand some basic rules, such as the prefix is always at the beginning of the term. That's why we call it pre. However, not all terms will have one. All right, so if we're talking about perfusion, right? Perfusion by itself doesn't have a prefix. It's just the root word. The suffix is always at the end of the term, and you're going to use a combining vowel pretty much only when you're trying to combine two root words, unless it just doesn't fit based on the letter. So here it says the suffix begins with a consonant. So to make it where you can actually pronounce it, you're going to want to put a vowel there, or if the term has more than one root word. Plural endings. Somebody tell me what the plural of bacteria is.
Bacteria.
Okay, you're not wrong. So bacteria actually is the plural for bacteria. What's the singular?
Bacteria.
Bacterium. There you go. So plural endings sometimes will end in a vowel usually. So when we always say bacteria, and the reason we do that is because we're referring to bacteria in general, right? We might be thinking of a single one, but if you're actually going to say a single bacteria, it's bacterium. Usually a singular word will end with a consonant, and then your plurals are going to end with vowels. Usually there's some exceptions, and you can kind of see them here. So when you're talking about a diagnosis or diagnoses, that they're both going to end in a consonant, so it's a little bit different. But the rest of these, you can kind of see how they fit. Singular words that end in an A change to AE. Singular words that end in IS change to ES. That one right there is standard grammar. Singular words that end in EX or IX will change to ICES, like appendices, apex to apices. Singular words that end in an ON or a UM will change to an A. That's your bacteria, right? So bacteria with an A is plural. The singular is bacterium. And then words that end in a US will change to I. So bronchus will change to bronchi. Special word parts. Prefixes can be used to indicate a couple things. So like here we've got numbers, colors, positions, and directions. So if it's a number, several prefixes are used to do this, such as half, 1, 2, or more. Somebody give me an example of 2. If you were to try to prefix a word, think chemistry here. What's 2?
Bye. Bicep.
Di. Right, like dioxide, right? What about 1? If you were to try to say 1 atom of carbon and 1 atom of oxygen, how would you say that? Mono. So, all right, that one, maybe I may have worded that one weird. If you're going to mention as a prefix to say 1, it's mono. So like carbon monoxide means that you have your carbon and only one atom of oxygen. If you had 2, it would be carbon dioxide. Some prefixes that indicate a number, you have uni. It's like universe, right? You have 1, but it depends on how you're looking at it. Di, DIPL, dipple, however you want to say that, can be 2. Um, that let's see, null would be 0. Prime, looking at like prime could be first. For those of you, anybody on here that deals with labor delivery? Nobody? We're going to get to the chapter, but it's going to be way at the end of the class. Okay. Give me an example. What's the word for the firstborn if it's your first pregnancy? If you know it. I don't know how close that is to your area of it. Well, trimester would be 3 months. That's what the tri means. But if you're a new mom, you're going into your first pregnancy or your first delivery, you are prima gravida, is what they call it. This is your first pregnancy. Yeah. Okay. Yeah. No. That's fine. You're like I said, we're going to teach you. That's I had 2 kids before I figured that out. So everybody learns at some point. None of that is common sense. Oh, you're fine. You're fine. All right. For colors, several root words are used to describe color. So we have like cyan. If I said somebody was cyanotic, that means they're blue. Luke, the Leuk, if that technically means white. So if you have leukemia, what do you think that means?
Elevated white blood cells.
Okay, so you're on the right track. Leukemia has to do with your white blood cells. Good, but are there too many of them or not enough?
Not enough. Too many.
Not enough. Leukemia. There's actually not a part of that word that says high or low. That's the tricky part of it. You just have to know that disease. But leukemia by itself basically refers to white blood cells. That's what the word breaks apart. Anything emia, EMIA, like sickle cell anemia, leukemia, any of those have to do with your blood. And leukemia means that you have a low blood count, so you're more susceptible to getting sick. When you do get sick, it hits you harder. You don't heal as fast. That kind of thing. Erythro is another one. Cero and melano. So any of those can refer to colors. Won't hit all of those, but you kind of get the idea. When you see them, when you actually see them being used in words, and you think about what those words are describing, it pretty much makes sense. Like cyanotic. I'm not somebody that knows a lot of colors, so cayenne. I really, outside of knowing the medical term, I really could have never told you what cayenne was actually a color of. But, and I may not even be pronouncing that right. But I know what cyanotic means and what cyanosis means, so I can pretty much tell you that cyan or cayenne means blue, because that's what that means. If somebody's cyanotic, that means they're blue, right? Their fingertips are blue, their lips are blue, that kind of thing. Positions and directions. If words are going to start, if a word you're looking at is referring to a position or direction, and we're going to kind of get into that here in the next section, you're going to be using words like this. So ab, ad, de, circum, like circumferential, peri, trans, epi, and supra. You're going to use a lot of these and not even realize you're using them. All right. Supra is probably the only one that you probably haven't used that much. But a lot of these, you say them all the time, and you don't even realize that that's what you're referring to when you think about the word. But we're going to get some practice with that tonight. All right, so some common direction, movement, and position terms. Directional terms we're going to start with. So you need to know the correct directional terms to discuss where an injury is located. We're going to have some fun with that tonight, and how pain radiates in the body. Some directional terms include right and left, which get used to the idea of when you're looking at a patient, if you're talking about something on the right side, that is your left, because you're talking about the patient's left and right. Superior and inferior. There we go. Okay. Superior and inferior, which is above and below. Lateral and medial. Lateral means out to the sides, away from your midline. Medial means toward the center. You have proximal and distal, and I spent a long time trying to get the difference between lateral and medial and proximal and distal across to a couple of students not long ago. They understood it. They like definition wise, they got it. They had it on paper, but that's a pretty. It's hard to explain, and sometimes it can really trip people up. We'll get that's probably going to focus the most on that when we're going over our practicing in a little while. Superficial and deep, ventral and dorsal, more like a front and back. So think like dorsal fin on a dolphin is on its back, ventral is on the front. Palmar and plantar, usually referring to, think about your palmar is your hand, plantar is your foot. Apex, where is the apex of the heart? Apex usually means the top, right? The pinnacle. Is the apex at the top or the bottom of the heart?
Is at the top?
You would normally think so. It's actually at the very bottom.
It's at the bottom. Yeah.
Yep. So the apex is where the two ventricles come to a point at the bottom. That's just a weird, doesn't quite fit the rules kind of thing with your anatomy. The apex of the heart is on the bottom, even though the apex typically means top. Don't ask me, I didn't write the rules. That's just how it goes. All right. So let's break these down. Superior and inferior. Superior part of the body is anything above or near to the head from a specific reference point. Now, here's the thing when we're talking about, and this is where the problem with medial, lateral, and proximal and distal come into play. There's two, you can't have any direction without a frame of reference, right? You have to have a starting point. If I'm going to say the gym is 20 miles away from me, or would you say the gym is 20 miles away? Are we talking about 20 miles away from where I am at? Or are we talking about 20 miles away from my house? Or, is it a fixed point? Does it just happen to be where I'm at the time? That kind of thing. So when we're talking about the directions for anatomy, I want you guys to think of one of two things. We're either talking about the direct center of the body, which you could picture that your spine is your midline, right? It runs right down the middle of you. So are we talking about closer to the spine? Or are we talking about closer to a reference point like the elbow? All right, that's going to be the key to understanding the difference between some of these terms. So superior and inferior. Superior is near to the head, inferior is near to the feet. So if I was to talk about the vena cavas that feed blood to the heart, the superior vena cava is closer to the head than the heart. It's coming from above the heart. It's actually all the blood from your shoulders and everything on up is coming in through the superior vena cava. It's coming down to the heart. The inferior vena cava is near to the feet, right? It's below the heart. All the blood from your lower body is coming up that vena cava, and they both dump into the right atrium, which we'll get to all that later, but I'm trying to show you how that works. Terms describe the relationship of one structure to another. So the knee is superior to the foot, but is inferior to the pelvis. And that is assuming that your body is in the anatomical position, which if y'all have never heard of that, that is where the body, the person is standing erect, which means upright. His feet are apart, usually about shoulder width. His hands are down by his sides, and the palms are facing forward. That is your anatomical position. So you might show up to somebody who's been in some weird wreck and they're in some weird contorted position, but it doesn't matter what position they're in. when you describe an injury, you're going to imagine them being in the anatomical position. So the knee will always be, whether they're right side up or upside down, the knee will always be inferior to the waist. The foot will always be inferior to the knee, no matter what you're looking at that particular moment. All right. Lateral and medial. So lateral means outer, medial means inner. We're referring to your midline. So imagine an imaginary line going right down your body, kind of like your spine. So if we're going to say something is medial, we're talking about closer to the middle. Your heart is medial. Your arms are lateral, that kind of thing. Proximal and distal. This is the one that trips people up. So I'm actually going to read this word for word out of my lesson plan, and then we're going to talk about it. Proximal and distal. The terms proximal and distal are used to describe the relationship of any two structures on an extremity. You're not going to use these terms on the midline trunk of the body or anything like that. If you're talking about the chest, you're not going to say proximal and distal. Yeah, it's medial and lateral. All right, that is your chest, abdomen, back, butt, all that stuff is going to be medial and lateral, first of all. Proximal and distal is for your extremities. Proximal describes structures that are closer to the trunk, and distal describes structures that are further from the trunk or nearest to the free end of the extremity. So when we're talking about injuries, and this is going to be when you use this the most, if I have an injury on my forearm, I've got a pretty good foot, I would say, 12 inches between my wrist and my elbow, probably a little bit longer. I don't know, I've never measured. But if I'm trying to describe this injury to you when you can't see it, if I were to just say I had an injury on my forearm, how do you know if I'm talking about an injury close to my wrist, say like a suicide attempt, or just a broken wrist, or something going on with the elbow? So what we'll do is we will say, all right, if I'm going to describe an injury and I'm going to place this to where you can understand what I'm looking at, I will say that I've got an injury to the forearm about 2 inches distal to the elbow. So if can you hear me, Kim? Can't hear, it's kind of skippy. Your connection may be faltering. When you're dealing, I'm going to keep going. Hopefully you can come back in. If not, there's the recording. When we're talking about proximal and distal, it's not about your midline. You're not talking about reference to the center of the body. We're referring to the nearest landmark. So if I have an injury near the elbow, whether it be above or below, in the forearm or in the bicep, that kind of thing, you're going to pick wherever that injury is at, pick the nearest landmark. It can be anything. It doesn't have to be the elbow. It doesn't have to be a joint. It can be whatever body part you feel comfortable talking about. Like it could be a hand. It could be, you can use the groin. You can use anything, unfortunately, sometimes you can't be shy. Just use what you got to. But you're using those landmarks to provide a reference point. And then you're going to say proximal or distal, saying if it's either further out from it or closer in. Superficial and deep. Usually we use these terms to refer to burns and other skin type injuries. So a superficial burn means it's pretty much just the surface area of the skin. A deep, the worse the burn, the deeper it gets, right? So superficial burns, just like, oh, I scalded my hand on water. Then you get your partial thickness or second degree and your full thickness and third degree, which is a deep burn. Those are burns and injuries. If it's a cut or whatever it is, that isn't just the top layer of skin. You're cutting through the skin, through the fat, possibly into the bone, that kind of thing. You're getting way down into your body. Superficial and deep is we use that to provide a 3D image. Like if I'm going to describe something to the doctor, superficial and deep is pretty much the only thing that will give you a 3D idea of how bad something is. Everything else you can look at on a 2D plane, like a piece of paper. So anyway, yeah, they use burns as an example here too. Ventral and dorsal. Again, picture your body in the anatomical position. Ventral is the front. That is your chest is ventral, your face is ventral. Anything on the belly side. Dorsal, like somebody said it in the chat too. Carmen put it in there. Dorsal fin. right? So we think about fish, dolphins, sharks, all that stuff. If they have a dorsal fin, that fin is sitting on their back. So you can look at that. More commonly used terms are anterior and posterior. They mean the same thing. You can use whatever you want. Anatomically, you may see ventral and dorsal, but in the medical field, we've adopted anterior and posterior a lot more often. So just be aware, you might see ventral and dorsal on your tests. You will definitely see anterior and posterior. And most of the people you interact with in your career are going to use anterior and posterior instead. Palmar and plantar. So palmar, palm of your hand, right? And then plantar, think like you're planting your feet. All right, so the bottom of the foot. Your apex or apices is the tips of a structure. We usually use apex, and because when you think about the apex of anything else, you're talking about the tip as being like at the top, right? The apex of a mountain, the tip of the mountain, the apex predator is at the top of the food chain, that kind of thing. But it's not always the top, so don't get confused with that. It's the tip. That is why the heart, the apex of the heart, is actually at the bottom. Some movement terms. You will use these. I don't use them that often because a lot of times I'm not trying to describe a limited movement, but that doesn't mean that you don't need to know them. And you're going to see these on your tests as well. So the following terms related to movement. Flexion is the bending of a joint, like, muscle man flexing at the gym, pulling his arm in. Extension is straightening. Adduction and abduction. These are moving either toward or away from the midline. The way I always remembered this, if you're moving something toward the midline, I'm adding it in, right? I'm eating, I'm enjoying, everything's coming into my midline, and I'm getting fat and happy. So I'm adding stuff to me. If something's being abducted, it's being taken away. You get abducted by aliens or what, however you want to look at it. That is being taken away from your midline. So adduction, you're adding things in. Abduction, you're pulling away. Other directional terms you may see, body part that appears on both sides of the midline is bilateral. So if I were to say that I had an injury to both femurs, both thighs, then that would be bilateral femur fractures. And the slide just uses anatomical objects. So your eyes are bilateral. Your nostrils would technically be bilateral. Your hands and your feet. Anything that has a left side and a right side would be bilateral. Lungs, kidneys, so on and so on. Unilateral means only one side. So if we're talking on an injury standpoint, if I broke my left femur, I would have a unilateral femur fracture. Unilateral chest expansion means that I have done something to screw up my chest on one side, be it like a popped lung or something, but the other side is fine. And so as I'm breathing, I might have unilateral chest expansion, where the one lung on the right side, for example, is breathing and inflating, but the left lung is popped, so it's not going to inflate. My chest is going to be kind of lopsided. So you'll see that term sometimes used. As an EMT, you should be able to describe the exact location of areas of the abdomen. This is really important. We're going to hit this stuff in anatomy. But again, remembering which quadrant has what, it takes some time. You can memorize, you can throw it into short-term memory and get it fine on the test and everything, but it's going to take practice. It's going to take time to be like, let me ask you this. The kidneys, for example, who thinks that the kidneys are in the upper quadrants versus the lower quadrants? Your quadrants are divided at the belly button. The belly button is like the 0 point on an axis. Everything above it is upper quadrants. Everything below it is lower. Do you think your kidneys, and no right or wrong, I know we haven't covered it, but just to kind of give you an idea, who thinks the kidneys are above the belly button? All right, we got a lower, well, bottoms, lower, upper. All right, Kim?
Everybody wants to play with us.
I think they're like right at the axis.
They're pretty much on it, but they're technically upper. So, yeah, there we go. People are hopping on it now. So, yeah, upper. For years, thought they were lower because of the referred pain. You hear about flank pain, and it's kind of low. The pain is below the belly button, but the kidneys are higher. Never thought about that. But anyway, so these are important. You have your right upper, right lower, and left lower quadrants. And that the dividing lines intersect with the belly button. So when we're doing our assessments, and you're going to do a lot of these at the boot camp, we're going to be going over scenarios of trauma and medical and everything. And no matter what you get, you're always going to assess the abdomen the exact same way. You're going to kind of poke and prod. And you're going to do it quadrant by quadrant. I'll go ahead and tell you now, if somebody tells you their stomach hurts, 99% of the time, they're not talking about their stomach. The stomach rides way too high. Everybody's talking about their abdomen. And if they can say it hurts right here and they're kind of pointing at that right lower quadrant, don't let that be the first place you poke, because they're not going to feel anything else anywhere else. All they're going to be doing is screaming in pain, and they're not going to be happy with you. So if you got somebody holding their right lower quadrant saying it hurts real bad, you want to you got to make sure that there's nothing else going on in the other three quadrants. Get those first, because once you start poking and prodding on the part where they're having the problem, it's going to override anything else they ever feel. They're going to miss it. All right. Other directional terms to describe the location of an injury or assess your findings. So this is important for you to do. This is how you talk to medical professionals, your doctors, your med control, other EMTs, paramedics, nurses, all this. Even if you yourself, actually, you know what? I'm not going to say that. So yeah, just get this down. You don't have to have it tonight. Like I said, I'm going to start using these terms with you guys from here on. I'm not going to use plain English. And if you guys use plain English with me, I'm going to have you go back and say it using your proper words, because I want you to make this second nature for you. All right, anatomical positions. We have prone and supine. All right, so if somebody is laying prone, they're face down. We don't like prone. Prone is bad. Prone usually means your patient can't breathe, so we don't want to keep them there. You might show up, patient's prone. We want to roll them over, and not immediately. I mean, there's going to be some things we check, and we'll get into that when we do the assessments. But prone typically is not a good spot to be in. Supine is where we want our patients. That's where they're laying on their back. Then you have Fowlers, and there's a couple of different variations of Fowlers. You have true Fowlers, which is sitting straight up, and nobody likes that. I don't know anybody that wants to sit straight up as a board. You have semi-Fowlers, which is kind of reclined, like you're in a recliner. And then you have the other end of that, which is basically the tripod position, which is also not a position we want to see our patients in, because that tells us they're having a hard time breathing. But semi-Fowlers is going to be for transport. The majority of the time, that's going to be how you transport your patients. We want them supine if possible when we're doing a head to toe. But a lot of times we're going to do position of comfort, which is normally semi-Fowlers, depending. Sometimes you may put them on their side or whatever. So semi-Fowlers is patient sits at a 45 degree, and a high Fowler, which is, I call it a true Fowler, but high Fowler is patient sits at a 90-degree angle. And like I said, I mean, I don't like sitting in that angle, even when there's nothing wrong with me. If I'm hurting, I really don't want to be sitting in that angle. All right. We'll take a break a little early today. It's I'm sorry, it's wrong time zone. It's 6:53. Take a 10-minute break. Get back 7:03, 7:05, anywhere around in there. We'll get back on it. Like I said, this is a really short chapter, so we're going to fly through this, and we're going to be done with the slides. So I'll see y'all in about 10 minutes. Only 8 slides Okay, so still on break. I just for some reason cannot get the text box. So let me click in it to start typing. So I'm to say this out loud. Carmen, did that work for you? First of all, I know you can type in the address, but oh wow, sweet. Okay, so that fixed your problem. That is weird, but it works. I'm not going to argue with it. Okay, John O'Hara, yes, you can call me as soon as we get done with class. I got no problem with that. Do you have my number? I can't type it to you. My freaking text box isn't wanting to work. As long as it lets you in, and that could be the problem. Maybe it was trying to log you in as a teacher, and that's why your login wasn't working. Email with it. Okay. Um, one way or the other, you can reach out to me. We'll get on the phone. If you don't have my number, shoot me an email, and I'll email you I'll email you my cell phone. I'm not sure. Okay, awesome, John. To the one who said you need to talk to me after class, do me a favor. Type your same thing. Um, I can only do one call at a time. That was the only thing. Is it something we need to talk in person or not? You, John. We are going to skip the "You Are the Providers" simply because I don't have my textbook. Um, so I'm not really sure. Oh, okay. Um, yeah, we can definitely talk later on after the class, sir. No, I don't have my textbook, so I can't really see the "You Are the Provider" portions. But you guys are welcome to it. If you want me to weigh in, if you want to do any of these things in the group, I can see them. I can't weigh in on some things as much as I want to on your discussions. Um, but if y'all want to bring anything into the Facebook group other than the actual discussions that you're doing in Canvas, I can weigh in. I can talk about some things with y'all and do some more training. So absolutely, let's utilize that group, not just for interactions with me, but also interactions with each other, because it'll help everybody in the long run. All right, a couple more minutes. We'll get back on it. Feel free to create some new ones. I put those together um, before the last class. They use them to try to help you guys think outside of the book. You know, like you'll learn all kinds of things a certain way in class, but it doesn't really. You're going to get on a truck, and then the first thing your paramedic or your partner is going to say to you is, "All right, forget everything you learned in class because the real world is different," and it is. But um, if you got to forget everything you learned in class, and that's a failure of your class. So I'm trying to not have that be the case. The discussions are just to let you try to think in a realistic point of view, and not so robotic like the actual lectures are. y'all might some of those discussions are meant for when we get to those modules. So you may wind up changing your opinion on a lot of your answers as you go through this class. We'll see. All right, time's up on the break. And at the same time, yeah, I really hope you get a good ride along as well, all of you. We try to put you on the closest ambulance to you, but let's be real. The training it doesn't do anything if you don't run any calls. So if your local ambulance company doesn't do anything, and not anything, but you only get 48 hours. So if they're prone to going 48 hours without a call, it may not be the best choice to ride with them. So give that some consideration. And if you need me to pick an ambulance that's like the next town over or something like that, or the next county over, and you're okay with making that drive, then let's do it. Let's get the most out of this. So, all right, continuing on. Let me get this slide back to full screen. Breaking terms apart. So medical abbreviations, acronyms, and symbols are a type of shorthand used for communication. This is developed because one can communicate faster using this method. Obviously, we always try to save time, right? So if I don't want to type or write out supraventricular tachycardia every single time I use that in a paragraph, I can just put SVT. That's a very well known acronym. Same thing with EMT. If I don't want to write out emergency medical technician every time I refer to an EMT, I can write EMT. But you got to be careful because in discussion, if I said EMT or ENT, if I'm flying through a sentence and you don't quite catch what I'm saying, you might not know if I'm talking about you as an EMT or the guy who cleans the crud out of my ears every now and then. So sometimes, and it's not just verbal stuff too. You got to be careful. Some acronyms have 100 different meanings depending on who you talk to. In fact, if you want to know, you can Google up an acronym, and there's websites out there that give you every use of it and tell you the organization that uses it. You can see how they overlap, and sometimes it can be really difficult. So we do have some acronyms that are very good that we use all the time. They're very well known, makes it easy. But there are some, if you're going to make something up or if you're going to use something yourself, it's fine. There's a way to do it. This says use only commonly understood acronyms and abbreviations to minimize misinterpretations and errors. If you're going to do something in your report that is an acronym that you're creating, you want to make sure you're in the right spot. Let's skip the part. Well, we already talked about this part. I'm sorry. Here we go. All right. If you're going to create your own acronym or abbreviation, now that my brain and my slides are on the same page here, put somewhere in there, preferably at the beginning, what that acronym stands for. So like I said, when we're doing your documentation, you can write out the word. If it's something you're going to have to write every single time, like 100 times in your report, write it out once, and in parentheses, put an acronym in there so that you've tied that acronym to that word. So even if they don't know what it means, as they're reading it, the very first thing they see is that acronym spelled out. Now, every time they see it after that, they know what that means. It's like our company, ARES, right? If you just heard ARES, what is that? What's the first thing that comes to mind?
Horoscope.
Horoscope, right? All right, so a constellation, or I think Aries is the Roman. No, Mars is Roman. Aries is the Greek god of war. So, or oh god, now I'm forgetting. Anyway, that's a tangent. I don't want to get on. My company and what those letters mean, is not the first thing that comes to people's minds. So, anytime we do something on a legal document, we have to actually spell out Advanced Rescue Education Solutions, and then we put ARES in parentheses, so that as we're going through that report or going through that document or agreement or whatever it is, we can just write ARES after that. That's an example. So the Joint Commission and the Institute for Safe Medication Practices are considered two authorities on abbreviations and provide do not use lists. There are some out there that you really should not use because they can really screw up the treatment plan for the patient. And a lot of this sometimes comes down more for your advanced levels of care, because they can refer to like medications that you've given or don't want to give, and they can be very easily mistaken, and then you've got some major problems on your hands. When you use an acronym, you're shortening several words, usually using the first letter of each word to make the acronym, and that's what that means. It's not really an abbreviation. It's just an acronym. Let me get back here. All right. So on abbreviations take the place of words to shorten notes or documentation. Remember to only use standard or accepted abbreviations to avoid confusion and errors. Abbreviations, you're probably not going to make too many of these up on your own. That's just it's not really accepted. If you're doing this in kind of a note to yourself, that's fine, because you know what your abbreviations mean. But if you're going to do something on a legal document like a patient care report or anything of the sort, try to stick to the commonly accepted ones, because just remember, ask yourself what happens if your report winds up in court. That's going to be the big driving factor there. You don't want to have to sit there and get derailed trying to explain what all of your abbreviations are if you can help it. Stick to the ones that are accepted. That way, that's one less thing that an opposing lawyer can pick your report apart about. Be familiar with accepted use of abbreviations in your local jurisdiction or service area. Some people use some that others don't. A good example, it's a tangent really, but it's just to kind of drive the point home, is 10 codes. Some of you guys may be in the fire service or police already, and you know what a 1050 means, or a 1025 or whatever, but I guarantee you that 1050 up here in New York and 1050 down in Mississippi are two very different things. Same with 1025, and that's a major thing, because 1025 up here, I forget what it means. I know it doesn't mean what it means down south, which is disregard. So if I'm a dispatcher up here and I tell somebody 1025, they're gonna, their red flags are gonna fly. If I take that same knowledge and go down south and do it, I'm trying to get somebody to rush to a scene or whatever, and I say 1025, they're gonna be like, oh, all right, cool, returning to service, and then somebody, it's a problem. So know your area. Sometimes they put it in your protocols. If they don't, talk to your employers. A lot of times your ambulance company, your fire department, they will tell you, or they'll have a list of what your stuff means. I was coming from Missouri and going to Louisiana, and they looked at me funny. Why? Yeah, 1025 in Mississippi means disregard because of the 1050 code. Oh, you tried. Oh, I see what you're saying. You used it, and it didn't make sense to you. Yeah, 1050 in Mississippi is a car wreck. I don't know what it is in Missouri or Louisiana. And then, I mean, even then,
Louisiana,
that's not,
it means no, negative 1050.
1050 means no. So yeah, okay.
Negative.
Yeah, see, that's the difference. And again, that's the reason why we try to get away from 10 codes. But that's a whole nother topic for, actually, we don't even cover in this class.
1050 for NBA.
Yeah, in Mississippi, it's the NBA. All right, symbols. So like abbreviations, symbols are sometimes used as a shortcut in communication and documentation, but as with anything, make sure that it's understood what it is. It's important to only use the symbols that are widely understood and accepted. And guys, that's it for the lecture. So it's only been an hour. I'm not going to shortchange you on getting some things done. This lecture was really, really, really short. So let's play a game. I am going to describe an injury to somebody. If I can get let me see if I can get this into type. I may not be describing an injury to somebody.
Oh, wow.
All right, so I can't type. I'm going to give up on typing. All right, so I'm going to tell you guys in plain English. I'm going to be your patient, basically. I'm going to tell you where I'm hurting, and I want you to tell me back. I tell you what, I'm going to call on people. No, I won't do that. That's mean. So text
Yeah,
it to me.
just pick somebody. That's cool.
I want to start with you, but
Okay.
all right. So text it to me. That way, everybody has a chance and nobody gets called out. But I'm going to tell you. I'm going to act like your patient. I'm going to tell you where I'm hurting, and you guys tell me in medical terminology what I'm saying. All right. So you can use your books, use Google if you want, however you want to do it. That's fine. I realize this is the first night that we've covered all this, so we'll wean you down to doing this from memory. All right. So my first complaint is that I am having a hard time breathing.
You said you're having a hard time breathing?
I'm having a hard time breathing. What word do you think would be best? Okay, so the COPD is a good one. That's more of a reason. Shortness. Okay, SOB. What does that mean?
You could be shortness of breath or
Shortness of breath. If I were to say, give me a word.
respiratory distress.
Okay, that's a good one. So now you can kind of see how there's a lot of ways to put this, right? There's no one word for everything, and that's a good thing. Now, there is one word that nobody has said. I'm curious if anybody's going to get it. It starts with a D. There it is. Dyspnea. All right. Again, be careful where pneumonia would be. That's not necessarily a hard time breathing. It would cause a hard time breathing.
I just said respiratory distress.
You did. So you're good. I was looking at the text. You almost spelled it right. There is DYSPNEA. So very close. And that was good enough that I didn't even catch that you misspelled it right off the bat. All right. Next one.
I can say it, but I can't spell it.
That's usually the case.
Wow.
All right. Try to stick to text just because there's 27 people in the class. And if I give one that everybody knows, I'm not gonna be able to hear. It's gonna be so loud. All right, so a couple ways to say trouble breathing. You have shortness of breath. SOB is a good acronym for that. You've got dyspnea. That's the actual term. So good job. And how you word that in your report is up to you. But any of those would have been acceptable. All right, so now let's say. Okay. My heart's racing. I can't. I just feel like it's beating out of my chest. Good job, Donna. You got it fast, but you sent it to me in a private message, so it wasn't seen. Sharon got it. John, say your last name for me. Is it Avera or how do you say that? Oops. Avery. Okay. All right. So a couple of you said hypertension. You were very good on the hyper, right? So you're thinking fast or thinking high. The only problem is, think about what tension stands for. So we didn't really mention that in class. Anything tension is about your blood pressure. So hypertension means you have high blood pressure. It's not necessarily the heart. It could be anything. The heart may be beating slow. Your blood pressure is high because your veins are constricted down. It could be any of that kind of stuff. So good attempts, and you're in the ballpark. This is where we start to learn these words and kind of figure out more specifically what they mean and how they work. If it would be a diagnosis, not necessarily a term, but that could cause, you're right, David, that could actually cause your tachycardia. Tachycardia is the word I was looking for. It just means a fast heartbeat. All right, let's see. Let's talk about an injury. I'm going to say that I have a pain in my arm, and it's right between the bicep and the tricep. I know you guys haven't gone over anatomy yet, but those are common terms. So let's see. Describe where that injury is located. And I'm going to say it's on the outside of my arm, on the outside, away from my body, and it's right between the two muscles. Okay, so we have a proximal to the shoulder. We have an upper arm pain, lateral, distal to the shoulder. Okay, it is distal. Depending on you use the right term group, but remember proximal. The shoulder would be proximal to the injury. In this case, the injury is distal to the shoulder. It's further out. Tendonitis is a diagnosis. Not really. That could be what's hurting. Yes, but we don't know that. So I'm looking for like using your directional terms to try to figure out where this injury is at. You're basically just repeating back to me what I said, but you're doing it with the medical terminology. So we have the closest one that I would say is the upper arm pain, lateral distal to the shoulder. The only thing, remember your lateral term, that is referring to things on the trunk. So if you're on the extremities, it would just be distal to the shoulder. I know what you're saying because of how I said it was on the outside of my arm. Just be careful about using those words there because it's not necessarily part of your extremities. Good job. All right, so let's say, you know what? Let's use the term tendonitis. If I said I had tendonitis, what does that mean? Inflammation of the tendons. Good. Now, here's an interesting thing. Who has ever gone and tried to do a new workout at the gym and they had the week of torturous hell of being sore in whatever muscle group they worked on? Yeah. There's always one. I mean, myself included. Well, not necessarily currently, but just in general. Like, have you ever experienced that? Okay. Yeah, I'll tell you what, that first week is usually, if there's anything that's going to make me not want to do a workout, it's that first week. So, does anybody know why you get sore? Like, what's causing that soreness? All right, Nathaniel, I'll tell you what, unmute yourself and let us, tell us what's causing that soreness. It's not necessarily that you're ripping your muscles apart, because you're going to rip your muscles a little bit every time you work out. But after that first week, you really don't hurt as much.
You're overexerting the tendon that you don't normally use.
Well, for tendonitis, if that's what you've got, yeah, you probably overexerted it. But just muscle pain in general. Say, you know what, you start a new workout, it's Monday, it's International Chest Day, so you're going to go to the gym, you're going to crank it out, right? Do whatever. Or you go running if you want to get into cardio. You pick your workout, whatever muscle group you're using. For the first week or so after you've worked out, it's going to suck. you're going to be sore. Every time you do something new that you haven't done before, you're going to be sore. And it's not necessarily that you're overworking yourself. It's just that you just haven't done it before. The reason that that hurts is because anytime the body sustains an injury of any sort, the way that it recovers is it sends fluid with all of your aminos and your proteins and stuff like that to that area to try to recover it. So when you go to the gym, you're purposely tearing fibers in your muscles to make them heal back stronger than they were before. I'm gonna go ahead and mute you guys real quick. Just a second. Just because there was a lot of background noise. All right. You're tearing up muscles that you in a way that hasn't happened before, and the goal is for them to recover a little bit better than what they were before. But again, to do this, your body has to get all the supplies to the construction yard to rebuild everything. That fluid takes up space. But this is important for a couple of things, and we're going to talk more about this in other chapters later on. But I want you guys to understand this process. And I know we're getting off topic here, but itis had me thinking about it. All the fluid that your body sends to recover a muscle after the gym or whatever workout, whatever new thing you did, that displaces that section of your body, and all that extra fluid is what hurts. Just imagine, like, if you've ever gotten a shot, a lot of times the needle doesn't hurt that bad. It's the medicine they're putting into your arm. You're sitting there, you're like, why? It almost feels like you got punched. And it's because that medicine is sitting there displacing your muscle fibers, it's pushing things out of the way. That's what's happening there. Now, under normal circumstances, like if you're doing this in a controlled environment, say like going to the gym, that's not a big deal, right? It's not life threatening. That's just part of it. It is kind of the same thing as, well, it's not the same as bleeding. We'll say that. Bleeding is just you've got a wound on your vessels. But anytime you want to recover, say like a tendon or something like that, your body has to send all that stuff there. Now to get it there, it has to use the blood vessels. So now we start to get into a couple different things. First of all, muscles heal faster than tendons because muscles have more blood vessels. The fluid gets there faster. Some injuries are a death trap for this body function. Burns, for example, when we start talking about burns, your body starts sending all this fluid to the skin to try to fix it, but the skin can't hold it because it's been scorched. So now you're going to be losing fluid. So the biggest concern for massive burns is dehydration. That's why paramedics are so worried about how much fluid to give people when they burn. Things like that. That's a body process. So we're going to talk more about that. I won't go too far off into the weeds any more than I already have. I just wanted to bring that up because that's an itis, right? So anytime that you sprain your ankle, go to the gym, which is a controlled environment, but you're still doing the same thing. You are technically injuring yourself in a micro-sized way to cause your body to have to heal itself, and it always tries to heal stronger than it was before. That's why we work out. That's also why it hurts when you start something new, though. All right, how about this? I'm going to give you guys medical terms. You tell me what it means. Pulmonary contusion. Has anybody ever heard of that one? You don't have to tell me what contusion means. Tell me what pulmonary means. Good. All right, bruised lungs, because pulmonary means lung. All right. What if I said I had hypothermia? Too cold. Okay. So too cold, yes, that is exactly right. Um, I like the low body temp a little bit better because instead of talking about a high extreme, you're more accurate with the hypo portion. So it's the frozen face. It's that your body temperature is too low. All right. Your body cannot maintain. Yeah. So you're just too cold. And that could be from anything. Sometimes we do it on purpose. We actually talk about induced hypothermia at the advanced levels when we bring somebody back from cardiac arrest. So it's not always a bad thing. Sometimes we can use it to our advantage. But y'all don't. EMTs, hypothermia is bad. All right. What if I said hyperglycemia? What would that mean? What AC after a hurricane? Y'all had AC? We didn't have AC for weeks after Katrina. Not blood pressure. Not blood pressure. Remember, blood pressure is tension. So yeah, high glucose, high blood sugar. That's what you're looking for. All right. Now here's one. This one, y'all may get this one, you may not. Supraventricular tachycardia. So that's 2 words. See if you can nail the whole thing. What does supraventricular tachycardia mean? All right. I'll slow it down because I suck at speech. Supraventricular tachycardia. Very good. Somebody nailed it. Justin Graham nailed it. Faster than normal heart rate. Yep. All right. So everybody got the tachy right. Tachy is fast. Supraventricular tachycardia means above, right? So supraventricular means that the source is above the ventricles. It's in the atria. And then tachycardia means that source is beating really, really fast. That is an abnormal heart rate. SVTs, we call them for short. Good job, Corey. And yeah, there's treatments for it that definitely includes Edison, right? If they're sick, if they're stable, they get medicine. If they're unstable, they get Edison, the electricity. All right. I won't torture you guys anymore tonight. I think that was pretty cool. You guys are pretty on top of it. So you've got a couple. You got the main ones. You know what hyper and hypo is. You know what super means. Inferior, superior. Below and above. Know this stuff. Know this stuff, because if you go into somebody's house and they tell you that they had an inferior wall MI, they're not gonna know how good you are at your words, right? So you may not know what an MI means, but if you heard that inferior wall MI, then whatever it is, there's something with the bottom. You can kind of piece together the words, and you tell that to a paramedic, and he's gonna like freak out. But you'll get that more as we go. So excellent job. I love the. I know that unfortunately you guys watching the recordings aren't going to see the participation in the text, but y'all did great. Those of you that watch the recordings, hopefully the YouTube posting will continue to work out really well. And try to go through these exercises on your own with it. And if you have any questions, let me know. But we're going to call it an early night. It's only 7:30. Y'all enjoy your night. Take the time to catch up. I know some of you are still trying to get. Oh yeah, I got to get that. Thank you. Some of you are still trying to catch up on your tests, so use this as an opportunity. We did just come out of a holiday. I know some of you were working through the holiday because y'all were in contact with me. I try not to, and I definitely don't have a class on holiday. All of our holidays that are on a Tuesday, Thursday, you're not going to have a class. Even the classes that don't fall on a holiday, I try to make your load lighter around them so that you can still take those holidays with your families, or get the power back on at your house from a hurricane. If there's anything you need, reach out to me. Your code for the night, give me a second to put one together. All right. All right. Tonight's code, B is in Bravo, C is in Charlie, 5, H is in Hyper, and the number 2. So you have BC5H2. I would type that, but I can't get it. I'm having technical difficulties too. It's not just y'all. So
Are you saying 5 as in number 5?
There it is. Yep. Somebody, Nikki Guido, got it for me. Thank you. BC5H2. Like some high quality H2O, but there's no O. All right, guys. Yeah, reach out to me if you need me. I know one of you's got to call me, and the other one, we'll talk as soon as we can afterward. Whichever one of you gets to me first. So y'all have a great night. I'll see you on Thursday.